Hello, everyone. Thank you for joining us for our talk. Our talk's title is called Determining Goals of Care for Seriously Ill Older Adults with Cognitive Impairment and Acute Respiratory Failure. My name is Kei Ouchi, and I'm an assistant professor in emergency medicine at Brigham and Women's in Boston. And I am really glad to be having an advisor who is Dr. Lum with us. And Dr. Lum, please tell us a little bit about yourself.
Hi, I'm Hillary Lum. I'm a geriatrician and palliative care physician at the University of Colorado and the Rocky Mountain Regional VA Medical Center, and pleased to co-present today.
Thank you, Dr. Lum. So as an emergency physician and Dr. Lum as a geriatrician, we hope to cover this important topic to figure out what the goals of care are for patients with serious illness in the emergency department. So we'll move right in. How do you advance the slide? We have no disclosures. So our outline for today, why will this help me, the clinician? Basic knowledge about intubation for older adults, and special considerations for seriously ill older adults with cognitive impairment. And then we will go through the EdCode status conversation guide. So first, why will this help me? I'm sure if you're a clinician in emergency department, you've gone through this situation where an elderly person is in respiratory failure and the family is asking you to save him, do something, doctor. And this is actually a common scenario. And often I went through training not knowing exactly what to say. So we started to look into how to do this in the best case possible. And of course, during our COVID pandemic, this topic is now more than ever. It's really important because mechanical ventilation is unfortunately getting more common during this respiratory illness. And we have possibly can hit situations where your beds are starting to run out. And emergency physicians must be really versed in figuring out what the goals of care are. My bosses, James Tulsky and Susan Block, always tell me, how are you prepared? Well, there are many best practices out there for this communication skills. And it just takes time for you to get really good at these. And we want to distill exactly what are the best parts that's most applicable for clinicians in emergency department. So I'm just going to go through some basic knowledge about intubation itself. ED intubation for older adults in general are just bad news. So approximately 35% of people who are older than 65 who get intubated in ED will die in the hospital. That's across all age groups. And blue is what those people who would go home, survive and go home after intubation. Yellow is those who survive and are transferred to nursing home or skilled nursing facilities. And red are those who are going to die. And as you can see, although age is just one factor, as the age increases, the proportion of people who die in a hospital certainly increases. More importantly, for older adults, their function, physical function, really changes after they go through an ICU stay. So this is including all older adults who are going into ICU, not just people who were intubated. And among them, as you can imagine, intubated patients have the worst outcome among the ICU patients. And this shows that if you start with mild to moderate disability, you only have about 32% chance of maintaining that function. So if you're lucky enough to survive, you will most certainly have severe disability. So do older adults understand that when we are talking to them about intubation? Well, patients say different things. So if you ask older adults who are hospitalized, on a survey, they would say things like 50% would feel that cannot get out of bed. That state is even worse than dying itself. So how can we best match what they would want to what they're actually looking at when they actually require intubation? So we just want to say a little word about special consideration for seriously ill older adults with cognitive impairment. Dr. Lum.
We wanted to share a few of these points, recognizing that when older adults come in critically ill, it can be clear that they don't have ability to speak for themselves or make decisions. So I think it's obvious this first point of recognizing having a high index of suspicion for impaired decision-making capacity. Then the question is, what happens if perhaps capacity or cognitive impairment is somewhat ambiguous or less obvious? And this is where, in the clinical setting, quickly, as you are asking about goals of care or asking about the next step for medical treatment, and the patient gives you an answer, then you can quickly ask why. So this, of course, is not doing a full capacity assessment. However, it can rapidly give you a sense of whether you should proceed with someone's ability to clearly express their preference, or if instead you need to pivot to identify and engage surrogate decision makers right there in your emergency department. We recognize certainly that this can be a process in itself, but spending your energy looking for the surrogate decision maker is important to emphasize so that you can then be having the goals of care conversation that we're going to be introducing with the appropriate parties. I think also important is searching through the medical record or asking surrogate decision makers if there are pre-existing out-of-hospital orders or any available prior advanced care planning documentation that can help inform the in-the-moment decision-making conversation that's going to happen. So just a few points to recognize quickly whether the patient is able to participate in the conversation, and if not, pivoting to identify the appropriate surrogate decision makers and ensuring that you are using any available or accessible documentation of prior discussions of goals of care is what we would recommend for older adults who are critically ill and may have cognitive impairment.
Thank you, Dr. Lum. So moving on, I will spend the rest of our time talking about EdCode status conversation guide that I have developed. So main goal is to identify patients who would consider the best possible scenario worse than dying. So let me explain what that means. First, we need to establish with patients that this is actually a crisis. As you saw in prior slides, intubation itself is already a bad news for the patients, and there's actually urgency in our decision making. So it's really important to establish that this is a crisis with the patient or the surrogate decision maker. So you can say things like, I'm sorry to meet you like this. Your loved one is very sick, and we need to make a decision quickly. Then the next step is to ask about what they know. So you can ask them about what have they heard so far about what happened today, because understanding how much they know and actually how well they were doing before can kind of give you a sense as to how far you want to take this conversation to, and also allows you to not repeat what they already know. And then the next step is to actually deliver the bad news. So it's important to give out a warning shot by saying, I have serious news. Would it be okay if I share this with you? And then deliver a headline, meaning clear and succinct way without using a jargon, deliver that bad news so that they can hear it. You can say things like, your loved one is not breathing well, and I'm worried that he may die. This is almost always followed by respondent's emotion, and it's very important to address that emotion head on and either use techniques like naming the emotion or something to alleviate that emotion a little bit, because no human can make good informed decisions when emotions really high and anxiety is really high. In a way, this is the time when many times what patients or families think that how ill they are is different from the actual clinical status. And our job in communication is to try to close that gap so that we can try to align their prognostic awareness to how sick they actually are. Then the next step is to really align. So what I mean by align is to establish a therapeutic alliance. We want us, the clinicians, to be on the same page with the patient or the surrogate, because we both want the same thing, to deliver the best care possible. So you can say it out loud and say, we will work together to decide on the best possible care for your dad. The next step is to ask about function and values. So this is the part that is really critical in order for you to make your recommendation later. You can ask questions like, how much was he able to do when he was well before today? Also ask probing questions like, what abilities are critical to live? What's the minimum quality of life that he would be willing to live for? So the reason why these 2 points, the function and values, are there is because by asking these questions and better understanding patients' baseline function before this acute respiratory failure, you can better assess how they would be in terms of function if they were lucky enough to survive. And you can assess whether that would be something that he would consider worth living for. In addition, allowing a surrogate or the patient to tell us how they viewed their lives and what kind of function they had, it's a process for us to help them see how sick they actually were. And then we summarize and say, what I heard you say is this, this, and that. Your dad would consider something like this really important, and this is the minimum quality of life that he would be okay living. Did I get that right? These steps will allow us to ensure that we've heard them and correct misunderstandings if there were any. Then you finally make the recommendation and say, based on what I heard about your dad, I would recommend intensive treatment focused on either comfort or being cured from the illness right now. You can say things like, I will do this and I will not do this. The critical patient values questions that you want to think about, and this is an escalating format, are really, how much would he be willing to go through for possibility of more time? Because it's not guaranteed that he may survive this hospitalization for sure. And what abilities are so important to him that he would not consider life worth living? And finally, what states would he consider worse than dying itself? These will give you a clearer picture of what he will be willing to live for. And you can formulate in your head, is that something realistically that I can offer him with best medical care possible? Whenever clinicians like us get stuck in these tough conversations, there are always helpful communication phrases that you can sort of fall back on. These include these wish statements, I worry statements, what I hear you say, would it be okay? These are all great words that you can always use when you are not sure exactly what to say next. You can always, almost always fall back on tell me more, because they will tell you more about what's on their minds, which in reality will decrease their anxiety because it allows them to talk more. So next time, when you have someone telling you, you have to save him, well, what he's really saying is, he looks really short of breath, so you gotta help him. And our initial clinician response is to tell them about the probability of survival, but consider responding directly to their emotion by either naming the emotion or saying things like understanding statements, respecting statements. All those can be found in best practices using Vital Talk model. So again, when you're not sure what to say, this is actually what happens in emergency department. A lot of times, many things are uncertain, and this is where we shine. So unless it's clear to us that the patient would consider the best case scenario worse than dying, we don't know for sure by trying to have this conversation, we have to fall back on intubating them. They can always revisit this conversation later on. So if you do so, you set it up for a time limited trial by saying things like, ICU team will talk to you again about whether this care is helping your mom in about 24 to 48 hours. By just doing this, the surrogate would hear the information one more time in a timely manner, and they would expect this. You are really helping the clinicians who are going to be caring for this patient downstream. So the take-home point for today is that we have to practice and use the guide that's based on best practices in other settings. And please consider requesting a three-way conversation with the palliative care team. We have done that during March and April in Boston, and that was really helpful for patients and surrogates, as well as ED clinicians, to sort of learn how to do that well with communication experts. And this is where I would end. Thank you so much for your time.